If you don't know how to treat, the easiest way is to look at guidelines and see what they recommend. And as you can see here, there are a couple of treatments that are recommended for advanced HCC, which is good because you have a lot of options, but it's also bad because you need to make a decision for one specific treatment. And sometimes it's really difficult to make a decision for one of the options we have. Just to mention the three that I will also discuss in my talk a little bit more in detail. Atezo-bev was the first positive trial, Dovatremi the second one, and the last trial we have seen Ipi/Nivo. There are more trials, but they have not been approved in the West, so they are not included here into the algorithms. Of course, we should try to do better, which means we should try to include patients into clinical trials, and we also need to think and consider local therapies also in patients with advanced disease. So to make it a little bit more complicated and also to highlight that it's really difficult to develop guidelines basically in HCC, we do have a lot of options available. And as you can see here in our latest update of the ESMO guideline, we highlight all the possible treatments in early, intermediate, and advanced stage. We do not have head-to-head comparisons, so it's really sometimes difficult to decide for one specific treatment, and it definitely depends a lot on local expertise. Looking a little bit to intermediate stage, also based what Riyad has shown us, I mean, in this version of the guideline, we have included the combinations of TACE plus immunotherapies. I'm favoring that. There will be an update of the ESMO guideline, and I can tell you already today that the update will look differently. But I think it's really important, and a very important question also Ghassan asked. So what should we do now with these clinical trials? We have 4 positive phase 3 studies. We have chosen PFS as a primary endpoint up front. The trials are positive, and now we start discussions on overall survival. I think, and I fully agree, overall survival is important, but as Riyad also said, in intermediate stage, maybe it's a little bit too early to really ask for an overall survival benefit, specifically when you power your study for progression-free survival. And I think since the trials are positive, we have a higher response rate, we have longer progression-free survival. These are valid options. And probably, I'm not sure whether we need to discuss so much whether PFS is the right endpoint. This is something for future trials. We need to decide now what should we do with these 4 positive studies, and should we just leave them alone and say, okay, it's good, nice, positive, but we don't do it because we don't have an overall survival benefit. I'm not sure that this would be the right way, and I think the combinations do have some value. The high response rates definitely offer us options for downsizing, downstaging, and this is something I also would like to highlight here in the guideline. We have this response-adapted treatment, which means once we start a specific treatment, it's not only about having at some point progressive disease, of course, but also we can achieve high responses, which are up to 70% with our combinations, which allow us downsizing to potentially curative treatment. And this is, I think, something that could really change the outcome for our patients, and something we need to do more, which requires tumor board discussions and teamwork in the end. In terms of really advanced disease, which also applies to those patients in intermediate stage where we think local therapies are not meaningful, we do have all these options. They are all listed here. In addition to what I have mentioned before, we have also Camrivo, which is not yet available in the West. You can also consider monotherapies with Durva or Tremi. We have positive data for that. I think one of the most important questions is, obviously, can we use the checkpoint inhibitor, yes or no? In 90% of our patients, I think we can, and then we can choose one of these options. In those where we can't, we always mention 2, lenvatinib and sorafenib, but looking at all the efficacy data in the latest studies, I think lenvatinib is clearly the more effective drug, and I would favor lenvatinib as an alternative to checkpoint inhibitors. In the second-line setting, we only have evidence for tyrosine kinase inhibitors after progression on sorafenib. Since we don't treat with sorafenib anymore, it's kind of an evidence-free area, but I think all guidelines recommend sequential treatment, and we will see more on Monday. When we now look at the 3 approved treatment regimens, the first one, as mentioned, IMbrave 150, atezo-bev versus sorafenib, all efficacy endpoint clearly improved, higher response rate, longer progression-free survival, longer overall survival. And the safety profile was clearly in favor for the combination therapies. I mean, for those that still used sorafenib in the early days, the diarrhea, fatigue, hand-foot skin reaction, that was really bad. And with atezo-bev, we really have a treatment that is very well tolerated in the majority of patients, and plus we have the high efficacy. Same for STRIDE. STRIDE has shown superiority compared to sorafenib, durvalumab, non-inferiority to sorafenib. We have clearly higher response rate. The safety profile is also in favor of the checkpoint inhibitors. We do have more immune-related side effects when we add tremelimumab. So adding 1 dose of CTLA-4 not only increases efficacy, it also slightly increases toxicity, and we have a slightly higher use of steroids for immune-related side effects, 10 versus 20%. What I'm not showing here, but what I really would like to highlight, that Himalaya is one of the first studies where we can really report 3, 4, 5, 6 years survival data, which is really exciting. And I think this is the really big difference we are seeing today. It's not about the median and the PFS of 3 months, 4 months, whatsoever. It is, we can report 5 years survival in HCC, and this is really exciting. And I think all of us who are treating HCC, we do see these patients in clinical practice, which we are really following for years and years and years, and that's really good. The last study that have been reported is a nivo-epi with a higher dose of ipilimumab that adds toxicity. We do have more toxicity compared to atezo, more immune-related toxicity compared to atezo-bev and STRIDE. In up to 30% of patients, steroids were required, but it also has a lot of efficacy. Response rates are up to 40%. Progression-free survival is longer. Overall survival is longer. Duration of response is getting up to 30 months. So that's exciting. It's an effective treatment. I would like to highlight, if you use nivo-epi in HCC, you can really induce an immune-mediated hepatitis. So I strongly recommend to monitor LFTs early on treatment, and there are many patients that require steroids to treat these immune-related side effects. This is basically a high-level summary of the data that I have just shown you, and you can see we do have a gradual increase in median overall survival. With sorafenib, it was less than 1 year. Now we are getting close to 4 years. Response rate was not existent with sorafenib in the initial study, around 2%. Now, as mentioned, we are going up to 40%, and also tolerability is clearly better. We do not have these typical tyrosine kinase inhibitor-mediated side effects anymore, so which means treatment is really better and well tolerated and certainly manageable with these IO-based combinations. Just to mention here, when we put this all next to each other, it should not be a cross-trial comparison. Of course, we do cross-trial comparison also because we need to do and need to make decisions. But one caveat is here. The IMBRAVE 150 study was the only study that included the so-called high-risk population, which up to 20% of patients, which include those with VP4, so main portal, vein infiltration, tumor burden over 50%, and also bile duct infiltration. And as you can see here, this is clearly highly negative prognostic markers. Median overall survival is clearly shorter, clearly less than 1 year in this population, in this high-risk population. Importantly, however, you can see that the curves are separating in both cohorts with a similar hazard ratio. So albeit these patients have a very poor prognosis, treating them with atezo-bev, with checkpoint inhibitors, is clearly meaningful, and we do see a better outcome. Of course, if somebody has an VP4, very likely these patients have portal hypertension, which means they are at risk for varices, and with that, they are at risk for bleeding with bevacizumab. So if you treat VP4 patients with atezo-bev, you certainly should do an endoscopy before you start treatment to avoid really running into bleeding complications. And while I have said before that it's exciting that we can report 4-year, 5-year, 6-year survival rates with our immunotherapies, it's getting even better. We can now report recurrence-free survival. And when we report recurrence-free survival, means we have achieved a complete response, yeah, and we can achieve now complete responses in patients with advanced HCC, with vascular infiltration, with extrahepatic spread, when we treat them with checkpoint inhibitors. And as we have done here in this analysis, which we published last year, the numbers are still low, no question. So we looked at almost 4,000 patients, and you can see 4.4% developed a complete response. So it's not big so far, right? But I think the door is opening, and now we need to open it further. But having and achieving complete responses is meaningful. Some of these patients are cured. And we have now interesting discussions. So how long should we treat with checkpoint inhibitors? Some of my patients do not develop any side effects. They don't want to stop their on treatment for 4 years. Yeah, so this is new discussions we are having now in clinical practice. Riad already mentioned we have 2 diseases, yeah, and this is, I think, is also one thing we always need to keep in mind, and maybe also one additional problem which makes it more difficult to look at overall survival, because our patients do not only die from tumor progression, they also die from their underlying liver disease and their underlying liver cirrhosis. And we do have different measures on how to look at liver function. Liver function is highly prognostic, as you can see here in the 2 lower Kaplan-Meier curves. So patients with Child-Pugh A, B, C have different survival from 6 months, 1 year, 2 years. And within the Child-Pugh A cohort, which most of us think they use it for their decision-making, we can distinguish 2 groups, IB1 and IB2. When I say IB, everybody is looking at IB, specifically here in North America. I hear very frequently, now I don't do IB, yeah, because IB is very complicated. Yeah, and if you look at the formula you need to calculate to get IB score, I agree, it's complicated, but it's not. It's very simple, because you only need to look at albumin and bilirubin. And if both are normal, you have IB1. So it can't be easier than that, right? You are not confused by ascites, not confused by encephalopathy. You just need to look at IB. And I tell you, each and everybody who's treating HCC is doing the IB score, because everybody looks at albumin and bilirubin. You just need to acknowledge if it's normal, IB1. If one of them is not normal, you're going to IB2, and that's most important, because there's clearly a survival difference. You think it doesn't really matter if bilirubin is increased, slightly increased, or albumin is slightly decreased, but it does matter. And if you look in the Kaplan-Meier curve in the middle, there's a 10-month survival difference, 10 months. This is nothing, we don't achieve that with any systemic therapy, a 10-month survival difference. And it's just driven here by liver function. So liver function is really important and something we need to keep in mind. When we now look at outcome, and this is kind of a summary, and here I'm also including the data for Camrivo, on the outcome according to liver function. Yeah? In all of these clinical trials, we only include Child-Pugh A patients, right? All are Child-Pugh A. But half of them, around half of them are IB1 and half of them are IB2. And you can see there are clearly differences in overall survival. So in the experimental arms, in IB1, you can always see these are those patients that have the best and longest survival. The longest survival maybe with Nivo-Epi, getting to 3 years median overall survival. Yeah? So that's really exciting, yeah? A strong difference. And if you look at the IB2 patients, you can see overall survival is always a little bit shorter, and sometimes we hardly see any survival benefits. So liver function is important, and it's not only important to look upfront for liver function, but also during treatment. And it's not only biochemical markers, albumin and bilirubin. It's also clinical markers, because our patients with liver cirrhosis can decompensate. They can decompensate with ascites, with encephalopathy. There are multiple ways to decompensate. And this is important. So we looked at the IMRE 150 study, and we asked the question, which patients have the worst outcome? Are these the patients that have early tumor progression, or are these the patients that have early hepatic decompensation? And if you look at the Kaplan-Meier curves, the worst survival is for those that have early hepatic decompensation. So it's not tumor progression, it's hepatic decompensation, which drives really a very, very poor prognosis. So liver function is clearly important, and it adds some complexity to the treatment of HCC. Second worst curve, of course, are those that have early progressive disease, not surprisingly, and best outcome for those that are stable and have no tumor progression. So no surprise for that. But again, here I think it's important to acknowledge hepatic decompensation is worse than having tumor progression. So this is something we need to develop. This is just a paper that was published 1 or 2 weeks ago. The question, how can we look at those patients that decompensate? In the end, it's not surprising. It's liver function again. Bilirubin comes up from IV score, so another reason to look for bilirubin. And albumin, platelets as a marker for portal hypertension, or vascular infiltration we have seen before is also poor prognostic markers. And if patients have all of this, vascular infiltration, low platelets, plus high bilirubin, poor liver function, of course, these are the patients at risk. But we need to acknowledge that. We need to look at this, and we need to be clear upfront when we have patients with these characteristics. We should treat them, but we need to be aware that they may decompensate, and we need to monitor this closely. Just briefly, what should we do in second line? So far, after checkpoint inhibitors, we don't have any data. We will report the IMREV 251 data on Monday. So here we ask the question, so once we have progression on atezo-bev, should we continue with atezolizumab, or should we switch to a tyrosine kinase inhibitor, lenvatinib or sorafenib, which was the control arm, and the experimental arm was the addition of atezolizumab. And it's great that this study was accepted, and we will present it on Monday morning. Last point, always interesting when you go through all these publications daily, how can we make progress? And I think many of you have heard before that the first dose of a checkpoint inhibitor may matter. We have now also data in HCC, and it seems to, if you apply the first dose in the morning, it seems to be better than in the afternoon, something very easily to implement and to consider. How do we proceed? There are a lot of drugs and trials and approaches coming. We will have a second wave of immunotherapies. We have new approaches, targeted therapies, targeted radiotherapy, which may be a competition for RIA then, which offers more options, right? Then we can also target patients with extrahepatic disease with radiotherapy. I think there are very interesting trials which are ongoing. We need to have umbrella studies like here, the Gemini study, where we test different drugs and combinations, and with that, I think we can certainly make progress. You have seen this before, and this is my last slide. I think it's really important that when we decide on the treatment of our patients, we need to decide upfront what are we aiming for, what is our intent for treatment, and then select the best possible treatment for our patients.